Ventilator Mastery Series, episode number 3, Severe Asthma, the silent test on the ventilator. Severe acute asthma is primarily a disease of extreme airway resistance, bronchospasm, mucosal damage, and mucus plugging narrow the airway dramatically. Unlike ARDS, compliance may initially be near normal, but resistance is severely elevated. The major danger is incomplete exhalation. Air becomes trapped, leading to hyperinflation and intrinsic PEEP, very similar to the COPD, but often more abrupt and severe. CO2 rises rapidly because expiration is critically impaired, but not because the patient cannot inhale. On the ventilator, the biggest risk is breath stacking. If the respiratory rate is too high or inspiratory time is too long, the patient will not have enough time to exhale. Intrathoracic pressure builds up, venous rhythm falls, hypotension develops, and cardiac arrest can occur from severe dynamic hyperinflation. Peak airway pressures are often high due to resistance, but plateau pressure may be relatively normal because the alveoli themselves are not stiff in the early phase. The ventilator strategy in severe asthma is built around one principle: maximize expiratory time. Tidal volume is generally set 6 to 8 ml per kg of ideal body weight. The respiratory rate should be kept low, often 8 to 10 breaths per minute. Inspiratory flow should be high, around 80 to 100 liters per minute, to shorten inspiratory time and extend expiration. The IE ratio should be prolonged, commonly 1 to 3 or 1:5, or even more if needed. Minimal external PEEP is typically used because adding excessive PEEP can worsen hyperinflation. Permissive hypercapnia is accepted as long as the pH remains tolerable, because aggressive attempts to normalize carbon dioxide will increase air trapping. If sudden hypotension occurs in a ventilated asthma patient, dynamic hyperinflation must be assumed until proven otherwise. Immediate ventilator disconnection to allow full exhalation can be life-saving. In severe refractory cases, deep sedation and sometimes neuromuscular blockade are required to control the ventilation and prevent dysynchrony. In asthma, the problem is not oxygen delivery alone, it is airflow obstruction. The ventilator must be used to buy time, while bronchodilators, steroids, and supportive therapy reverse the underlying bronchospasm.